Good afternoon. My name is Julian Suzanski. I'm a graduate of the RCSI class of 2010, one of the OGs, the original JEP class. Currently, I work at Henry Ford Hospital in the emergency department in Detroit, Michigan. I'm going to be talking to you today about lung ultrasound, and in particular, why I want to talk to you about this is as it relates to our current worldwide pandemic of COVID-19. As of this moment, I have no treasure trove that I'm sitting on and no conflicts of interest to discuss with you. What I'd like to do is take you through some basic principles of lung ultrasound today. We're going to describe some artifacts that relate to lung ultrasound and how that can help you determine different types of pathology, and then also recognize pathology that we can see with lung ultrasound, such as pleural effusions and consolidation or collapse of the lung, and then finally talk about how lung ultrasound can help you in the current pandemic. So why do I want to take you through this? Well, first of all, for those of you who work in emergency departments, ICUs, or as hospitalists, and you're on the front lines routinely triaging COVID patients, this can be incredibly helpful. It's faster to obtain than your standard chest x-ray. You don't have to wait for anybody to interpret it or it to be processed. It's very easy to repeat this exam, whether it's you repeating it on a patient you're taking care of or you passing it off to another provider who's then repeating the study. It's very easy to reproduce. It's cost effective. And when you compare ultrasound to our standard imaging modalities, such as chest x-ray or CT scan, you're going to find that it's superior to chest x-ray in detecting pneumothorax, in detecting normal aeration pattern of the lung, and also in detecting alveolar interstitial syndromes. And you're going to find that it's equivocal to CT scan. There are many papers published on this now. Over the last 10 years, then there's been an explosion of point-of-care ultrasound in the medical field. And this is just one paper that I grabbed a number of years ago, but it shows of point-of-care ultrasound, lung ultrasound compared to CT scan. And you can see that the sensitivity and specificity for picking up some of our common diagnoses are above 90%. Remember, sensitivity allows us to rule out a pathology. And so in a very small occult pneumothorax, ultrasound is not great for ruling it out. However, if you see findings consistent with that, it's 100% specific. And so it can really, really help you when evaluating medical patients, but also when evaluating your traumatically injured patients, particularly your blunt trauma patients. So some nuts and bolts of how we're going to do this. First, which transducer am I going to use? Well, the answer is any of those in the picture. If I'm specifically looking for pneumothorax, and that's my number one question, I'm going to use the probe that's in the center of the screen here, the linear probe. It's high frequency. It allows me to see the pleural line in a lot of detail, and so I can pick up those lung sliding artifact. If I'm looking for pathology like pneumonia, or a pleural effusion, I'm going to use a low frequency probe that can penetrate deeper into the body. And so the probes on the two extremes of the picture are going to be my go-to, either the curvilinear probe or the the microconvex probe. The phased array probe will also work, but I prefer a linear probe kind of setup. How am I going to position my patient? Well, ideally, you're going to have them supine. You're going to use some basic principles of physics, gravity. All right, fluid is going to sink to the bottom and air is going to rise. So if I'm looking for an effusion or a hemothorax, I'm going to look down by the diaphragms. If I'm looking for a pneumothorax, I'm going to be more up in the apices of the lung, looking there. I'm going to remember my anatomy and use that to help me identify the anatomical landmarks on ultrasound that I'm looking for. So you're going to have your probe indicator pointed up towards the patient's head or in the longitudinal plane. You're going to identify your rib spaces, and then you're going to look at your ultrasound screen and identify your anatomy. So you're going to be moving from anterior to posterior or superficial to deep as you scan through. So at the top of the screen is going to be your skin and your subcutaneous tissue. Then you're going to hit the pec muscle. Below the pec muscle, you're going to see the intercostal muscles. And then below the intercostal muscles, you're going to see your pleural line. Adjacent to that fascial plane between the pec and the intercostal muscles, you're going to see your ribs, and they're going to create a shadow, a dark artifact below them, because ultrasound gets, it cannot really penetrate through the bone. And then we're going to have our pleural line, which is where we're going to be looking for sliding in the case of pneumothorax, or artifacts to be generated when we're looking for different other kinds of pathology. So some of the basic principles about lung ultrasound is that first, lungs contain air, and air is the enemy of ultrasound, all right? Air causes sound waves to scatter. Just like when I'm talking to you in a room, my voice automatically fills the room, the sound waves travel in all directions. When we're ultrasounding, we want that beam to travel through a fluid or a medium like soft tissue, and it's going to travel in a straight line and return back to the probe to help create our images. So when the sound waves hit air, they scatter in all directions. We don't get that return signal. So what we're looking for is that pleural interface. And we're looking for artifact that's going to be created there. As I mentioned before, when the thorax is full of fluid, as in an effusion or a hemothorax, or when the lung is collapsed or there's a mass, then there is some soft tissue that we're able to image through, and we'll actually be able to visualize interior contents of the thorax. Make sense? I hope so. So first questions I ask when I start performing a thoracic ultrasound, all right? Number one is there lung sliding? Is it, can I see it or can I not see it? And then number two, artifacts that I'm looking for generated from that pleural line. And those common artifacts that I'm going to take you through are A lines, B lines, and Z lines. And then any other findings like effusions, consolidations, or collapsed lung. So first, let's start with sliding, all right? When you identify your structures, you're going to find the tops of those ribs, look about 1/2 centimeter below the rib, and you can actually visualize the lung sliding back and forth here, just like our Mr. Turtle on the slide, all right? It generally, if the patient's breathing normally, it moves fairly slow, and you can kind of see a shimmery artifact moving back and forth. This is a linear probe, high frequency. This is my go-to when my question is there pneumothorax or no pneumothorax? In contrast, when there's no sliding, you can see in this image that we don't see any sliding at the pleural line. So we're identifying our ribs, shadow underneath them, about 1/2 centimeter below the tops of those ribs, we're going to see the pleural line, and we can see that there's no shimmering going on there. If you're not certain, or you're just starting in using lung ultrasound, you can use other modes of ultrasound to help you confirm this. One common mode is M mode. Another mode is power Doppler. In M mode, you see just what happens down this raster line demonstrated on the y-axis as depth, and then the x-axis is time. So in the image on the left, we see that as we move through the pec muscles and then the intercostals, they don't really move with normal respirations. As soon as we hit that pleural line, we get movement and we get a lot of static as it appears underneath. This is known as the seashore sign. So this is supposed to be the sandy beach, and these are the waves coming into the shore, and that's normal lung sliding. As opposed to that, when you have no movement and you look down that raster line, you get horizontal lines all the way across the screen. And in the literature, that's referred to as the stratosphere or the barcode sign, and that's concerning for pneumothorax. But what does not sliding really mean? Well, it insinuates that there's possibly a pneumothorax if you have a traumatically injured patient and your clinical suspicion is high enough, but it doesn't necessarily mean that. There are other things that can cause absence of lung sliding. So some common things would be patients who've had pleurodesis performed and their pleura now adheres to one another. You can get really bad COPD, emphysematous patients that have big blebs, and there's no sliding when you image over one of those blebs. So if your suspicion is for pneumothorax, just remember, no sliding doesn't always mean pneumothorax, and you really want to take it one step further and look for a finding called lung point. Lung point is going to be the transition between collapsed lung and normal aerated lung as it slides back and forth between a rib space. And it looks like this, all right? And so if you look from the right side of the screen, you can see a rib, and then from underneath that rib, aerated lung slides into the left and then disappears. And we have no movement over here on the left side of the screen, which with the indicator pointing up towards the patient's head would be the more superior portion of the lung zone. And that would represent pneumothorax. This is your most sensitive and specific. So sensitivity, 97%, specificity, 100% for lung point. So indubitably, you've found your pneumothorax when you find one of these. Other artifacts that I'm going to look for at the pleural line. First is going to be A-lines. A-lines represent normal aerated lung. When ultrasound travels through tissue and then hits the lung, it encounters an area of the body of very different density. You see this at two places where ultrasound encounters bone as it's traveling through soft tissue, and when ultrasound encounters lung as it's traveling through soft tissue. This difference in density of the two structures creates a lot of reflection of sound waves. And so what we get are these horizontal lines that are equally spaced going down into the thorax that represent normal aerated lung. And these are referred to as A-lines. B-lines represent fluid at the distal alveolar and pleural interface. They appear on the ultrasound image as hyperechoic cones that radiate down deep into the image. They are hyperechoic. They move with the pleura. As more edema increases, the individual B-lines consolidate and form larger B-lines, and they obliterate A-lines as they travel down. Pathologies that can cause this, pulmonary edema from CHF, a little interstitial fluid leak during like a pneumonia, and then COVID can be associated with this as well. Here's another example of B-lines. On the image on the left, you're seeing some just individual B-lines that are traveling down into the screen. And then on the image on the right, you're seeing the coalescence of B-lines and this hyperechoic waterfall that they create down into the lung as the lung slides back and forth. When you see B-lines, you will see them sometimes associated with lung sliding and sometimes without lung sliding. B-lines without lung sliding is pretty conclusive for a focal pneumonia in that specific lung zone. The final artifact at the pleural line that I'd like to review with you are Z-lines. Z-lines are small comet tail artifact. They're hyperechoic and they radiate a short way down the screen. They do not obliterate A-lines, and what they represent is just a normal pleural artifact, an irregularity within the pleura. The pleural line isn't always perfectly smooth, and so as the little nodule kind of transitions back and forth underneath the probe, we get this little artifact generated. This is a normal finding. It is not pathologic. Here's just some other examples of Z-lines. They've been described as ants marching to kind of help you identify pleural sliding and that there's motion there. They also have been referred to in the literature as K, L, and M lines. So depending what paper you're reading, you may see them referred to as different structures. In the emergency medicine world, the Z-line has kind of become the most kind of common reference to them nowadays, or comet tail artifact. So what can we see on in the thorax? So fluid and masses and consolidation. So the image on the top here is a large pleural effusion. We're in the inferior portion of the lung, scanning down in the lower zones. And so you're seeing the diaphragm, the spleen, and then you're seeing this anechoic area, which represents some simple fluid collection. And then inside, you can see something moving. This is going to be collapsed lung, and it moves with respiration, but then it also has an extra little wiggle to it. And we call that lung pulse, all right? And that's just the heartbeat affecting the lung. And it's been affectionately termed the jellyfish or fishtail sign, all right? That little extra wiggle that it gets. On the bottom image here, what I'd like to draw your attention to is inside the collapsed lung, all of a sudden we get this hyperechoic bright artifact, all right? That's referred to as the shred sign, and that's the transition between collapsed lung and aerated lung. As mentioned, air is the enemy of ultrasound, and it causes that hyperechoic artifact and inability to see past it. And so you can see that shred sign. You can also sometimes see dynamic air bronchograms as air kind of penetrates through into a collapsed area of lung, which can be concerning for infection. So just stills to review that. So anechoic area is going to be an effusion. This is your collapsed lung, and it shows up similar to liver or spleen as its heterogeneous echogenicity. All right, and then we have the transition between collapsed and aerated lung that is referred to as that shred sign. And it's going to create that hyperechoic, hazy artifact as you do it. All right. And what is the shred sign? How does it correlate to on X-ray? Well, it would be this kind of patchy infiltrate that you're seeing over here on the right side. All right. And it just represents a area of consolidation, and then aerated lung behind it. So depending on where you work in, you may have heard of different lung ultrasound protocols. I work in the emergency department, so we primarily use two. We use a 2-point when we do an extended fast exam, where we look at 2 views on either side of the lung. And then prior to coronavirus, I was doing an 8-point scan, which was 4 segments on each side, kind of only looking at the anterior and lateral and neglecting the posterior, because generally patients were sick, they wanted to lay down, they didn't want to roll over when we were scanning them. If you work in the ICU, the most prominent protocol, I think, is the blue protocol published by Daniel Lichtenstein, but there are numerous protocols, and depending on what your workplace is, you'd want to review the literature and choose one that works best for you. This is the one that we developed for coronavirus, divided up into 6 fields, each side of the lung, incorporating the posterior fields for 5 and 6. Make sure when you're scanning in a coronavirus infection, you're protecting your equipment as well as protecting yourself. For our butterfly IQs that are handheld, hook up to our iPhone, it's awesome. They all fit inside a sterile sheath, and we just tie it up and we're good to go. For our traditional ultrasound machines, we covered them with a 50-gallon clear plastic bag that the touchscreen still worked through, and then we covered our probes with the standard sterile sheaths when we went into the room. Everything got wiped down before and after entering the room, as well as a 2-minute drying period where it would get wiped down again. So let's show you how lung ultrasound can play a part in COVID. So this is a 53-year-old male who presents to the emergency department with fevers and shortness of breath. This was in late April. This was height of Detroit being a hot zone. And we were really struggling with who we keep in the hospital, who we could send home, and how do we determine that, because all of us had not had a lot of experience with COVID-19. And so one way to do that was to utilize lung ultrasound to help make diagnoses quickly. Now, this is an extreme example, and so just because it has some good findings, but unfortunately time limited today, so can't give you all the examples. But in R3, you can clearly see some B lines coming down. You can see a little bit of an irregular pleural line. In R2, you can also see some B lines starting to form in addition to R1. When we look at that third lung zone, again, we see a little subpleural consolidation, and this was kind of one of the pathognomonic findings in coronavirus infection. These small, irregular subpleural consolidations, they could develop as small or they could get bigger. And then there was another thing referred to as a skip lesion. You're seeing one come in and out here, but it's an anechoic or a dark region within this B-line waterfall that moves with the lung. And I'll have another picture of that for you in a second. This is kind of the posterior and lateral zones where we know coronavirus infects the most. And you can see that really irregular and thickened pleural line with some areas of subpleural consolidation. This was referred to as crazy paving. And you'll see that particularly in the posterior and in the lateral zones. All right. So you can see how tachypnic this patient was just by looking at the ultrasound. This was on 6 liters of oxygen. These were his standard imaging findings. So his chest x-ray showed multifocal pneumonia. His CT scan didn't show any large pulmonary embolism burden, but did show significant bilateral pulmonary infiltrates. All right. And you can see that our ultrasound was able to pick that up bedside before we had either of these studies done. One of the primary points here is that you can prevent exposure of your radiation techs. You can prevent downtime of your CT rooms by doing these point of care ultrasounds and still, confidently make these diagnoses. Just to show you again what a skip lesion is, you're going to see it underneath this rib. It's going to slide out and then back in at the beginning of the clip right there. It was just a little anechoic region underneath the pleural line. So when you're seeing that B-line waterfall, you all of a sudden have an anechoic region that's moving with the pleural line. And we found that pathognomonic with coronavirus infection. So in conclusion, don't forget what you learned in the anatomy lab with Dr. Tom Farrell when you're using ultrasound, all right? You have to remember your anatomy, imagine what you're gonna be looking for, and then go to look for it. I'm incredibly thankful to have the lessons that were taught to me over the course of my time at RCSI. Dublin was amazing. I met some of who I consider the best doctors out there, as well as lifelong friends. And I think the experience that we gained was invaluable. It prepared us not only for the daily practice of medicine, but also for facing challenges like the world is seeing right now with this worldwide pandemic. But enough reminiscing, back to ultrasound. All right, so you're gonna take your 6 zones, or 12 zones, I should say, that you've scanned. You're going to take your clinical history and your physical exam. You're going to combine it with the images that you're seeing and the pathology that we've reviewed, and you're going to come up with your differential diagnosis. There are algorithms to help step you down this. Again, as I mentioned before, the blue protocol is one of the best algorithms to kind of take you through and figure out if the diagnosis is CHF and pulmonary edema, COPD, potentially PE, and then nowadays coronavirus is going to be on that differential. These are fast to perform. These artifacts are easy to recognize. I've just introduced you to them. If you start doing them, you're going to have no problem doing this in future. Your sensitivity and specificity is going to be better than that chest x-ray, and it's going to be on par with the CT scan, and it's going to help you prevent exposure to your colleagues and ability to triage your coronavirus patients if we do see a second wave and these things do pump back up. All right. I'd like to thank you for your attention. I'd specifically like to thank my fellow from last year, Dr. Akshay Srikanth. He was one of the big promoters of point of care ultrasound and got us using it in the triage process, and it was highly effective. Dr. Chris Clark, he made some of the images that you saw, the diagrams, so I was kind of stealing those from him, but I hope you appreciated it. And then Dr. David Mpanza, he was my mentor in my fellowship and continues to be my mentor now as I embark on my career. And so I'm thankful to have those people helping me along the way and helping me with this presentation. If you'd like any references, I'm happy to provide them for you. My email address is there on the screen. Please feel free to say hello. And if you need any resources, I'm happy to pass them along. And I wish you all the best. And I'm sorry that we're not there in person, but hopefully next year. All right. I think RCSI is probably the best medical school in the world. Thank you.